Case 10 begins with a stabbing incident at Dapitan. PS is a 40-year-old female walking down the street at Dapitan, busy texting her friend. Suddenly, a man interested in her cell phone stabbed her at the right side of the back, and then she was rushed to the ER of USTCD. From the patient's medical history, she is a 40-year-old female, and prior to admission, she was stabbed at the right side of her back, at an unspecified location on her back, and then she was rushed to the ER of the USTCD, where she displayed shortness of breath and tachypnea.
So next, I'll be discussing the normal radiological image pertinent to the case. So first, we have your normal chest X-ray. In an X-ray, bony structures absorb the most radiation, appearing white on the film, while a hollow structure containing air will appear dark, such as your lungs. Standard X-rays are performed with the patient standing 6 feet away from an X-ray tube. In evaluating if you have a good chest X-ray, you could check the position, penetration, full picture, and full inspiration. But if you are suspecting a case of pneumothorax, an expiratory film is better because during inspiration, the visceral pleura is pushed to the periphery and will be less visualized. But here in the example is in full inspiration. So checking good quality chest X-ray, trachea should be equidistant between the clavicular heads. The spine should be just transparent to the cardiac density, showing good penetration. And in full inspiratory effort, the anterior end of the right sixth rib should point midway along the right hemidiaphragm. The contour of the hemidiaphragm is dome-shaped, and usually your right hemidiaphragm is one intercostal space higher than your left. The costophrenic sulci encircled in red, both left and right, are sharp. If it's blunted, you could suspect pleural fusion fibrosis. In the thorax, the ribs and intercostal spaces should be equal to one another comparing left to right. If not, there could be presence of fluid or air. Next is checking your cardiothoracic ratio, which is usually measured by ratio of the maximal horizontal cardiac diameter to the maximal horizontal thoracic diameter, and usually the normal measurement is 0.42 to 0.5. So in lateral view, you can see what's behind the heart and base of the diaphragm. The blue arrow points to your retrosternal space, and if it's obliterated, it could be a right ventricular enlargement, while the yellow arrow points to retrocardiac space, and if it's obliterated, it could be a left atrial enlargement. So usually the costovertebral angle. Next is your normal chest CT scan. In CT scan, air appears black, which is called hypodense, while the bone appears white, which is called hyperdense. In the chest CT, you can assess the lung parenchyma, pleura, airways, mediastinum, the heart, the vessels, the soft tissue, and the bones. Usually a gold standard for assessing pneumothorax. This is a section of a non-contrast chest CT in an axial plane. There are a lot of sections in the CT scan. I choose this picture because it's similar to the given picture in the case. It's usually good in evaluating your lung parenchyma. The lung is an air-filled structure that is hypodense on CT. The branching structure encircled in orange are vessels or pulmonary vessels coursing through and tapering out to the periphery. One should exclude increased attenuation on the lung parenchyma because those could be typical abnormalities that your lung airspace is filled with blood or water. The green circle is your pleura that lines both the lung and the thoracic cage, and there is a potential space that contains a small amount of your pleural fluid.
So interpreting the given image, for the first image, we have the patient's chest X-ray. So the following shows an image of the patient's chest X-ray on upright position. The white arrows appear to be a finding of a positive visceral pleural line, and this indicates that the right lung has moved away from the parietal pleura. Comparing the right lung with the left lung, it can be seen on the left lung that this visceral pleural line is not visible since the left lung is still adherent to the parietal pleura. a positive visceral pleural line occurs due to an increase in intrapleural pressure brought about by air entering the intrapleural space. Next, let us focus our attention on the red circle. This appears to be a finding of a positive deep sulcus sign, which is an abnormal deepening of the lucency of the right lateral costophrenic angle. If you compare this with the left side, it may be noticed that the right side is darker, or in other words, more lucent than the left side. Also, the diaphragm at this point is lower than its counterpart on the left side. Lastly, there is also a widening of the costophrenic sulcus. If you compare it with its counterpart on the left, it can be seen that the left side has a sharper and more narrow costophrenic sulcus, while it is wider on the right side. So these two findings, namely the positive visceral pleural line and the positive deep sulcus sign, are common radiographic findings for a pneumothorax. The following is an image of the patient's chest CT scan. The white arrow is pointing to a lucency found at the right anterior side of the patient's chest. This corresponds to air in the right anterior intrapleural space. Additionally, when comparing the right side to the left side is wider while the left side is more narrow. And this is due to the air on the right compressing the left side of the chest. This is another typical finding for pneumothorax, but now on the chest CT scan.
In this slide, we could see a brief pathophysiology of pneumothorax. To aid us in our discussion, I color-coded each box. The one colored in red are the clinical manifestations and radiologic findings present on our case. Blue is for the etiology of pneumothorax, and yellow for signs and symptoms present in the classical presentation of pneumothorax. First, we define what pneumothorax is. Pneumothorax develops when air, as the result of disease or injury, enters the pleural space. There are two etiologies of pneumothorax. The first one is spontaneous, which can further be classified as a primary and secondary. Primary occurs without underlying lung disease precipitated by increased intrathoracic pressure, and the second one is a secondary spontaneous pneumothorax, associated with an underlying lung disorder such as tuberculosis, pneumonia, and COPD. The second etiology is traumatic. Like spontaneous pneumothorax, traumatic pneumothorax can also be classified into two. First is iatrogenic, due to procedures such as lung biopsy and positive pressure ventilators. The second kind of traumatic is non-iatrogenic, caused by stab wounds, gunshot, or rib fracture. This causes disruption of parietal or visceral pleura, causing acute onset of severe, stabbing chest pain, and in our case, dyspnea. The disruption of the pleura then causes air to enter and fill pleural space, acting as a one-way valve, and this consequently widens the costophrenic sulcus, thus appearing as a deep sulcus sign on chest X-ray. As air further increases, there would be an increased pressure in ipsilateral hemithorax, appearing as a visceral pleural sign, and a mediastinal shift away from ipsilateral lung, appearing as tracheal deviation. Increased pressure in hemothorax causes lung collapse. Thus, in physical examination of a patient, we would appreciate decreased tactile fremitus, hyperresonance, a decrease or absent breath sounds, and a decrease in chest wall expansion. An ipsilateral lung collapse also impairs gas exchange, resulting in a ventilation perfusion mismatch, leading to hypoxia, and the patient may experience tachypnea, and he or she would also have low SpO2.
The first differential is emphysema, which is a condition where air sacs in lungs are damaged, creating a larger airspace, reducing surface areas. It is usually caused by chronic smoking, and its clinical presentation are tachypnea, barrel chest indicating hyperinflation of lungs, shortness of breath, and hyperresonant on percussion. For the radiologic findings, it characterized as widened AP diameter or barrel-shaped chest, sexy or small heart, widened intercostal spaces, flattened diaphragm, and hyperinflated lungs. This may consider as one of the differential since the case presented with hyper-aerated lungs on radiologic finding. This is the PA view of patient with emphysema. Blue line shows widened intercostal spaces. Red line denotes same level of right and left hemidiaphragm, which normally should be right is higher than left, while orange line shows small or sexy heart due to pressure presses on the cardiac parenchyma. This is the lateral view of the patient with emphysema. Blue circle shows markedly widened retrocardiac space, which is normally less than 2.5 cm, while red circle shows hemidiaphragms are depressed and flattened with loss of the normal acute angle. In this view, we can also see the widening of the AP diameter, which indicates barrel-shaped chest. This finding can be ruled out since emphysema commonly affects both sides of the lungs, which does not manifest deviations, and there is also no visible visceral pleural line, which is radiologic finding of pneumothorax because air trapping in emphysema is within the lung tissue, unlike in pneumothorax, which can be found in pleural space. Emphysema is also usually come from chronic smoking, but not from trauma, just like in the case.
One differential for our patient is pneumomediastinum, which is the presence of extraluminal gas in the mediastinum, usually caused by an acute or chronic pulmonary disease. The gas may originate from the lungs, the trachea, the central bronchi, the esophagus, or the peritoneal cavity. Common causes of pneumomediastinum include asthma, blunt or penetrating trauma, esophageal perforation, tracheal perforation, infection, and surgery. As for the radiology, small amounts of gas may appear as curvilinear lucencies outlining the mediastinal contours, such as gas anterior to the pericardium, also known as pneumopericardium, gas outlining major aortic branches, also known as the ring around artery sign, gas outlining the bronchial wall, also known as the double bronchial wall sign, or gas elevating the neonatal thymus, also known as the angel wing or thymic wing sign, and pneumomediastinum may also present as subcutaneous emphysema, which is the presence of air underneath the skin. Pneumomediastinum presents itself in many ways radiologically. The left picture depicts the double bronchial wall sign. Air in the mediastinum, as well as both the right and left main bronchi in this picture, allows for visualization of both sides of the bronchial wall. Note the red arrows, showing the hyperlucencies indicating that there is extraluminal gas within the bronchial wall. The right picture depicts pneumopericardium. Take note of the inflation between the heart as well as the pericardial sac. That empty space indicates that there is presence of air within the pericardium, also known as pneumopericardium. And above that, there is a lucency of note, which indicates that there is air within the superior mediastinum.
Another differential could be the skin fold shadow. It is a curved shadow that is projected over the lungs, which can mimic the visible pleural line seen in pneumothorax. It is a frequent artifact on AP view, and it is caused by the compression of redundant skin of the back against the film. It usually occurs in older patients and those who had recent weight loss. Radiologic findings show curvilinear opaque shadow over the lung that gradually fades on hilar side, sharply defined lucent linear lateral margin, and there is no mediastinal shift in skin fold shadow. This can be considered since shadows present with a sharply defined linear lucency, which can mimic the visible pleural line seen in the patient's radiograph. The left radiograph shows that there is a curvilinear well-defined edge seen in the red arrow, projected over the lateral aspect of the left lung, which parallels the chest wall. There is a linear lucency projected as well at the left lateral chest wall. On first inspection, the appearance is very convincing for a left-sided pneumothorax. However, on close inspection, it is noted that vascular markings extend beyond what would be the pleural line, and the would-be pleural margin is not a thin white line, but instead a 1 centimeter thick white line which fades medially and abruptly stops laterally. Vascular markings in pneumothorax would be completely absent. The appearance is therefore that of a skin fold which is mimicking a pneumothorax. Initial X-ray was misinterpreted as being a left pneumothorax, and a CT scan was ordered to look for a cause of spontaneous pneumothorax. The CT scan reveals no thorax or no lucency found in the pleural space, but does nicely demonstrate the multiple skin folds which have created the artifact on the X-ray. We can rule out skin fold artifact because there is no curvilinear opacity seen in the patient's radiograph and no vascular markings seen beyond the visible pleural line. The CT scan of the patient shows lucency on the pleural space, which points more to a pneumothorax instead of a skin fold shadow. Partial airway obstruction leads to ball valve or check valve phenomenon, wherein the airway is not yet completely obstructed and there is air trapping in the affected lung field. Air can enter the lung during the inspiratory phase but cannot get out during the expiratory phase, leading to hyperinflation. Causes of partial airway obstruction are foreign body obstruction, bronchiectasis and cystic fibrosis, asthma, interstitial lung disease, infections such as epiglottitis and tracheitis, allergic reactions causing laryngoedema, tumors, retropharyngeal abscess, and airway trauma. Clinical presentation shows agitation, dyspnea which is present in the patient, cyanosis, wheezing, and moderate respiratory distress such as tachypnea which is present in the patient. Radiologic findings show that during the expiratory phase, partial airway obstruction inhibits the exit of air from the affected lung, producing air trapping with persistent hyperinflation of the obstructed lung and shift of mediastinum toward the opposite side. Partial airway obstruction can be considered as a differential since there is the patient's radiograph that shows hyperinflation of the right lung. Patient had dyspnea and tachypnea, which are some of the clinical manifestations of partial airway obstruction. On the left side is a chest radiograph that demonstrates moderate hyperlucency and hyperinflation of the right lung. A mild deviation of the mediastinum toward the left chest is noted. On the right radiograph is the right side down decubitus view of the chest, which fails to show the expected normal collapse of the right lung in this position. This supports the presence of air trapping in the right lung due to a non-opaque foreign body. Partial airway obstruction can be considered since there is radiolucency seen in the right lung of the patient, signifying hyperaeration. This can also be considered because the stab wound might have caused airway trauma to the patient. However, this can be ruled out since there is no findings of visible pleural line in partial airway obstruction, which is the finding of pneumothorax which is present in the radiograph of the patient.
For the final diagnosis and basis, traumatic pneumothorax was considered because the patient has a history of trauma located at the right side of the back, resulting in the presence of dyspnea and tachypnea. Positive visceral pleural line and positive deep sulcus sign are some of the typical demonstrations of pneumothorax, and these two imaging findings are present in the case of our patient. There are two common classifications of pneumothorax. We have simple pneumothorax, which is without mediastinal shift to the contralateral side, and patients are clinically and hemodynamically stable. For tension pneumothorax, accumulation of air within pleural space due to free ingress and limited egress of air. Contralateral shift of mediastinal structures are found with clinical evidence of tachycardia, hypotension, and dyspnea. Important note, if tension pneumothorax is diagnosed clinically already, do not request an X-ray and start treating the patient.